Hello, everybody. Welcome to the podcast, Redesigning Normal. I'm your host, Andrew Southern, and today I'm joined by Matt Ernst, who is the Vice President and Director of Operations at Oxford Physical Therapy. Thank you for joining me, Matt.
Yeah, thanks for having me. Appreciate being invited to speak.
Yeah, I'm really excited for our conversation. Why don't you tell everybody, we can get started maybe if you just tell everybody a little bit about the business and about maybe how you came to be Vice President and Director of Operations there.
Sure, yeah. So Oxford Physical Therapy is a private practice physical therapy company. We do outpatient orthopedics, so bones, muscles, sprains, strains, post-surgery type things. Kentucky and Ohio have direct access, so you can come straight to a physical therapist. And so we really think that people should enter, the musculoskeletal system at physical therapy. Most times you go see a physician, they say, hey, let's try physical therapy first. So we offer people the opportunity to come to physical therapy first. The company was founded in 1992 by Ken Rushi and Pete Zulia in Oxford, Ohio. And they thought, we'll have a PT clinic in Oxford, Ohio. So it'll be Oxford Physical Therapy. And to their, delight and surprise, I think, it grew. They had 8 clinics in Ohio. My brother and I partnered with them 13 years ago, started the first clinic in Northern Kentucky, and we grew that to 5 clinics. So we have now 9 locations in Ohio and 5 in Northern Kentucky, as well as an on-site industrial program that we do preventative medicine in for people that are working on, machinery, people who are working in construction, to help them prevent injuries and do ergonomics and intervention in that aspect.
Oh, wow. You've got a site just for that?
Well, that part of our business is more mobile. We go to the employer versus them coming to our office, because hopefully we're working with them upstream of injury before they even get hurt.
That's a really cool service.
Yeah. So I was full-time patient care for a number of years, and just as things evolved, became more and more involved in administering the practice and just running different things. And so my role now as Director of Operations is just basically ensuring everything's consistent from patient treatment, patient recruitment, documentation, billing. So kind of everything that touches, the service of delivering our physical therapy in terms of both how we get our patients, treating our patients, billing our patients, and getting patient satisfaction.
So because you have, I think you described 14 locations, you're able to sort of standardize, I imagine, at least the administrative things, right? I mean, certainly every patient's different, but the billing and the communication and everything, I imagine, is consistent across the different locations.
Yeah. So we have one office that does all of the billing. Each clinic does their own billing, and that rolls up to our corporate office. And then we have managers at each office, and all the managers, have similar instruction. I like to say that 85% of the office is the same. 15% is different. Some offices may have niche services or be in a different location. We have some clinics that are like in a gym, so that may be a little different than a traditional clinic. So there's nuances that are different at each location.
Got it.
But we want those services to really be standard.
Okay. I mean, that makes a lot of sense. Are there like big regulation differences between Ohio and Kentucky?
There's not big regulation differences. As I mentioned, fortunately, both are very favorable on the practice of physical therapy with direct access. And that's the biggest thing, is allowing patients to come directly to physical therapy. So Ohio and Kentucky both have really favorable rules with that. There is different licensure in each state. So we have all of our professional staff licensed to practice in Ohio and Kentucky. And actually, we were really, really happy that we did that when COVID did hit, because it really allowed a lot of flexibility when we had to, close down and bring back staff in a graduated way. We could have people kind of rotate clinics, if you will.
All right, cool. Well, we'll get into that. I think you may have answered the question then. Like, you became a partner in this 13 years ago, I think you mentioned. That's how you got to be the Vice President and Director of Operations.
Yeah, so there's 5 owners, the 2 co-founders, and then 3 people have joined as partners over the years, my brother and I being 2 of them. And then there's a partner, Rob Schwab, who's a partner in one of the Ohio clinics. And basically, we all have different talents, and we just felt like someone needed to be ensuring consistency and just managing kind of the operations so that we made sure that everything was not only done, but done well. You know, we're
Sure.
physical
Yeah.
therapist owned and operated. So that's a little different. There's a lot of PT
Okay.
companies out there that are owned by corporate entities or owned by hospitals or physician offices. And I think we have a different perspective, being that we're physical therapists. We know, you know, what the physical therapist challenges are, what their needs are, as well as what the needs and challenges are of the patients. So I think that allows us a different perspective, being PT owned and operated.
Got it. Got it. Well, I mean, you're the right guy to talk to then. Let's back it up to like February, March 2020. When
Yeah.
did you become aware of COVID-19 and how that it may affect your business?
Well, I would say in early March, we started seeing very high cancellation rates. I mean, our
Okay.
cancellation rates typically run 10 to 15%. Those, the week before we shut down the company, it was 40%. And
Which is bizarre,
so,
right? Like that's kind of weird.
yeah, very, very high, you know,
Okay.
and, you know, I think it was just people were afraid of the unknown, you know, some very legitimate concerns, if our patients had health issues or whatnot. But, you know, I think if you remember back to when the whole, you know, kind of hysteria hit, like people were just out of their mind. They're buying toilet paper. It's like, you know, it was just crazy. So I think
I
it was,
remember.
you know, I think it was just, that's when we started to know something's going on here.
Sure.
And then our challenge was, because we do operate in 2 states, we wanted to try to have one consistent set of policies in terms of how we were handling this situation for both our patients and our staff.
Right.
And the states were handling how they treated physical therapy a little bit differently. So that kind of impacted how we had to respond.
You have to take the more restrictive of the 2 states.
That's what we did.
Yeah.
We ended up taking the most restrictive approach, and we ended up closing the clinics. And then, you know, we were mandated to close temporarily in Kentucky. Ohio deemed physical therapy as essential right away. Kentucky
Okay.
later came back and deemed physical therapy as essential just a number of days later.
Yeah, because people would be like mid like recovery from something, right? That they need
We
to like
fought-
work through.
We fought very hard to be essential, because if
Sure.
you think about a patient that had surgery on Friday and was due to come to therapy on Monday,
Yeah.
all of a sudden we're closed, not deemed essential, that patient's surgery could be a failure because they don't get proper care post-operatively. So
Okay. Yeah.
thankfully,
I mean, sorry, go ahead.
no, I was just say, thankfully, we were able to reopen, and there were certain criteria that patients had to meet for us to be able to see them. So if you had sprained your ankle, unfortunately, we weren't able to help you at that time. Versus if you had a knee replacement, you know, you fit certain criteria of being urgent and emergent, we were able to see you. And
Got it.
that was a very, I mean, the whole process was gut wrenching, closing our clinics
Sure.
that we'd built so hard for. But I think picking and choosing who we were able to help, because to us, we're therapists. We're like, we're going to help everyone. You know,
Right.
it doesn't matter to us if your problem is quote unquote urgent, or if it's just, hey, you still sprained your ankle, you can't do what you want to do. So we're just kind of programmed by default to want to help everyone. And so it's very
course.
difficult to have to tell patients, no, we can't see you. You don't fit the criteria that we've been given by the states and government to be able to help you right now.
So how long do you figure you were actually closed in Kentucky? Like
Yeah,
before you
so
could reopen?
the entire company was closed about 2 weeks, and then we started a gradual reopening, where we would open each office 1 day a week, and we had a rotating crew of essential, you know, partners and essential people that have been with us for a long time that would basically go and open the clinic for that day and just see that clinic's essential patients, or, you know, urgent and emergent
Right, the
patients.
urgent ones that were deemed by the state to be urgent enough to come in.
Yeah.
So that's difficult. I mean, not only is that difficult pretty much for everybody, right? For the therapists, for the patients, for the administrators, everybody.
Yeah. Yeah, it was tough. I mean, the patients were like, "Where's my normal therapist?"
Right.
Hey, I was working with so and so, and we just unfortunately, we couldn't have people working if we couldn't treat patients. And the scope of who we could see was so narrow that it was basically just a small crew. Now, what we did is fortunately we were able to go from 1 day to 2 days to 3 days to 4 days and build it back up.
Okay.
And I mentioned earlier we have some clinics in gyms. When the gyms weren't able to open, and some of those offices we weren't able to open.
Oh, right.
So that
Because
made
your
it
locations
additional.
were you're like nested inside the gym.
Correct. Yeah. Yeah.
Okay.
So some of the gyms were private and owned, like an owner operator gym, and they were comfortable with us being in the gym, no problem. Some of them
Sure.
were more corporate owned, and their policy was if they weren't open, we couldn't be open. So
Sure.
it was a bit different in terms of each location, but even when we got the okay to start opening for physical therapy, we still had that limitation because some of our landlords weren't open yet to allow us to do our work.
Got it. But so within by May, you guys are sort of like back going again?
I would say June.
June, okay.
We had all non-gym clinics open 5 days a week. As a small business, I mean, we're in this to help patients, number one, with physical therapy, but number two, any small business owner operator will understand we just had to pace payroll with our volume. And at that time, PPP was so new and so many questions about it and what could it be used for, would it be used for, and all those sort of things. We just didn't even know how that was all going to come to play.
Sure.
So
Yeah.
as we had volume, we returned staff. And a lot of it was, again, I think an appetite on the consumer or the patient, because at that point, folks were very afraid. They weren't leaving their home for groceries or whatever. So
Right.
they were content to put up with a sore back or neck and maybe put off care, and elective surgeries were shut down for a number of weeks as well. So, the patients that we would normally see after surgery weren't coming because that surgeries had been shut down.
Got it. Right. So the whole thing like slowed.
Exactly. Yeah. I mean, our non-operative cases came to a grinding halt because people's activity level dropped. They weren't going to the gym. They weren't doing 5Ks. Sports weren't happening in high school and middle school. So,
Sure.
That eliminated, a lot of that activity. And then the elective surgeries were eliminated. And so it took a solid, I would say we were not, in September, we were about 65% of our volume as far as compared to pre-COVID levels. And even today, we're still at about 80%, 85% of our volume. We still have to practice social distancing in the offices. And so, we don't have folks spaced out, but we're still continuing that practice. And so that still eliminates some of what we can do.
Sure. Well, I was actually going to ask about kind of what other stuff you had to implement by June, and maybe that you're still doing, or in order to make certainly your team feel comfortable and your returning customers and your new customers to feel comfortable.
Yeah. Well, I think initially, we had been doing telehealth for a while, but insurance companies really didn't look favorably on telehealth and reimbursement for physical therapy. So and patients were like, well, if I have to pay, I would rather just come and see you in person, which I totally get.
Yeah, me too.
So obviously COVID changed that a little bit. So we had to do a lot of training with our staff because in the beginning there was only a very, very few of us that were trained to do telehealth because the volume wasn't there, the demand wasn't there. So training all the staff to do telehealth. We obviously had to change our total patient check-in process. I mean, in the beginning, even acquiring surface scan thermometers was difficult. Like,
I remember that.
I remember having decisions like, can we open this office, because I don't know if we can find a thermometer to scan patients,
Right.
and that was a real struggle. And are we going to be able to find enough gloves and face mask, So there was a real procurement issue, because in our normal practice pre-COVID, those were like minimally used. We never used face mask, and very rarely used gloves unless we were doing something post-operatively, changing sutures or staples or something like that.
I see. Yep.
So all that stuff had to be obtained. So lots of that, attainment of stuff and procurement of that. We changed the cleaning solution that we used to be, more potent cleaner.
Sure.
We had to rewrite policies and procedures related to that. And then obviously, when staff were called back, train them all on, how to do that. It's not that we weren't cleaning things before, but it's quite different in a PT clinic if you clean something after every touch versus cleaning something maybe at, 2 points of the day. We would clean the entire clinic,
Yeah.
So quite a lot of procedural differences that unfortunately were a lot of activity, but not a lot of productivity, It was just a lot of work that really, unfortunately, didn't benefit the patient, in terms of helping their outcome. Hopefully we kept everyone safe, and we didn't, yield a bunch of transmission from patient to patient or staff to patient.
Sure, right. Particularly, I remember like in the earlier half of COVID, there was a lot of like that touch concern, right? And there still is, but people were like, I remember like, washing their grocery, like the wiping down the milk carton. I don't know that everybody's doing that so much anymore.
Right.
Maybe the data has sort of determined that is less of a transmittable way, of getting that particular disease. However, that hasn't changed the idea of still like cleaning surfaces and stuff in a public space or in a clinic, right? Because that, it seems as though from the consumer's perspective, like seeing that happening and feeling and understanding that that's happening is still comforting, even though they may no longer be like washing the broccoli, or that broccoli is a bad example because you would wash it anyway, but you know what I mean? Like washing the milk carton or something.
I think there's a lot of, perceived safety that goes into it, So, I mean, simple things like at our front desk, we have a pen to sign in. So we created a dirty and clean pen bin.
Yeah.
And, just a simple thing like that made folks feel comfortable that they were using a, fresh pen every time, and I don't think the transmission rate would be that great, but, it's just something that, again, a comfort level.
Yep. So what do you think, I mean, does that bring us to sort of like now, just as we're recording this, the end of March 2021, have you basically had those things in place and been operating kind of as you described up until now?
Yeah, that I would say that's pretty much where we are. We didn't return all of our staff, sadly. We had to make some tough decisions, and some of our support personnel, if a physical therapist would have an assistant or have a tech, right now with social distancing, the physical therapist patient volume is going to be less, so they don't need as many support personnel or assistants.
I see.
Initially, it was an exposure point because we wanted to limit additional people in the office, so we went to just the very minimum. We needed a physical therapist, but the physical therapist in every instance didn't need an assistant. That was just another potential source of, exposing the patient, and then you're exposing the therapist. So we were just keeping that circle very small. Now we're, pretty much just waiting, hopefully, on some of the mask mandates and social distancing mandates to expire as cases continue to go down. Fortunately, all of our staff has had access to vaccines, and we have had really good luck with that. It was very difficult, I would say, in the November to January timeframe, as cases were really, really high, trying to keep the clinics staffed because we had very conservative protocols in place if someone exhibited any symptoms to immediately remove them from the clinic so they didn't contaminate anyone else or any other patients.
Yep.
You know, so when you have to do that and you have to wait, for testing or quarantine, it makes it hard to keep a continuum of care for the patient when you have to take that clinician out from a safety standpoint. So
I see. Right. It sounds like it was certainly a difficult logistical issue for staffing, and I'm sure also for your team, because some people can't unfortunately be there anymore because you've become a slightly smaller group, and then the ones that are there have to sort of now adhere to these new practices, which and I've never done physical therapy. I guess thankfully I haven't had the need to, but I imagine this is fairly touch.
Yeah, it is. It's physical.
Centric.
Our focus, one of the cornerstones of our company, is manual hands-on therapy. So we do a tremendous amount of mobilization. We do dry needling. We do cupping. I mean, we're constantly using our hands to help people get better. And, I can't say enough about our staff. I mean, they have really just rolled up their shirt sleeves and collectively done every single thing that we've asked them to do, and for the benefit of their patients. They were all so committed to wanting to get back to be able to help their patients get better. And it's really been cool to see. That's been just so tremendous.
I can imagine that even could be frustrating. If somebody's in the field, and I think you mentioned, you were also a physical therapist before you moved into sort of administration. So for whatever reasons, and I know many people like this, where like touch is important to them, like to be able to touch people and to do stuff. And if you're in a business where you're touching people all the time, and that's your job, and that's how you help and how you fix people, right? Yeah. To now have barriers between you and the patient with literally like gloves and stuff, you're no longer getting the same connection with your patients that you may even have known for a while. That could be very frustrating too, I think. Yeah,
it is. I think that collectively there was a lot of frustration. There was frustration on the patient's standpoint. I mean, they understood, but they didn't like it, and the therapist didn't like it either, and we as a company didn't like it, and all of us, I think the world collectively was in a place where we're like, nobody likes what's going on. How do we get through this together? And, I just think our staff did a tremendous, tremendous job. So I'm just really proud of them.
Amazing. Let me back up for a second and just ask you how, like, before you became a partner and then the vice president and the director of operations, how did you get into physical therapy? Like, if we rewind further.
So I always wanted to do something, I think, in the health fields. I originally thought I wanted to be a pharmacist, and I worked in a pharmacy, and it wasn't for me. I didn't like it. There was no person interaction. It was just kind of, to me, it was count 20 of these, hand them to you, and count 20 of the next and hand them to you. And so then I had some injuries myself in high school and did some physical therapy, and I thought, this is pretty cool. And I started working in a PT clinic, and I just really liked getting to know the patients and finding out what they wanted to achieve, and then being able to see, in the course of a number of weeks, we take people from a standpoint where maybe they're literally unable to walk. And they may be at the end of a month, not only walking, but running and back competing in a sport. And so I just think that's really cool. And to take home something at the end of the day that's not just a paycheck, but take home that impact you had on that person's life is really, really cool to me.
And I'm sure that the world of physical therapy like matures, and there's like new exercises and new science that you can sort of implement like as your career goes. Like, we used to do it this way, but we do it this way. But the fundamentals are, if your shoulder hurts, there are things you can do to strengthen this area, right? Right. And if we do these things and we're consistent about them, I can help you. And that is probably super satisfying. And I know this because my father is a doctor. He's an allergist, and he had told me that he liked allergy because it's a well-known. I mean, there's always new drugs, but like if you come in and you have particular symptoms, chances are, with the right medication, you can fix it. And you can give someone something, or in your case, like show them what to do, and then, like you said, over time, like they get better, and it's like it's a 1-to-1 thing.
I love working with a skeptical patient. I mean, I still, in my role, I still do patient care, and actually now, post-COVID, I'm kind of like the utility float person. I go and cover since we don't have everyone back.
Sure.
But, you know, when you meet someone and they're like, well, I really don't know if this is going to help me, and you do the evaluation and you think in your head, like, I've seen this, you know, now I've been doing this over 20 years. I've seen this before. I know I can help you. We do some things, and the patient's like, I feel so much better. When can I come back? You know, and literally an hour ago, they're like, I don't think this is for me. So that's really, really cool.
That is amazing. And now, between the 14 locations, like, what's the furthest distance?
So we span from Dry Ridge, Kentucky, south, up to Beaver Creek, Kettering, north. Okay. Yep.
So what is that for miles then? Like if you go from
about 150 miles, I guess.
Okay.
Yeah.
And so that's like if you're a floater in the practice, like you could potentially be going like to those.
Yeah, I try not to go there. I mean, I visit all the offices.
Sure.
You know, but try to be intelligent about it and help out. You know, try not to treat in lots of different clinics each day because it's too variable for patients. But as we bring new staff on, you know, I may go and help get a clinic built up, and then we bring someone on or back from our pool, and then go to the next place and kind of help get that going. Got it. And that's kind of what I've been doing lately.
Got it. Again, I don't know as much about the profession, but I was actually meaning to ask you this. This is kind of maybe unrelated to redesigning things, but when you are treating somebody, I imagine you'd prefer that they're not like taking a painkiller or something because they wouldn't be able to like feel their
It depends.
body.
I mean, it depends on what we're treating, you know.
Okay.
In terms of I would say most times we tell patients take whatever normal medication you would take. If it was like a post-operative patient, sometimes we'll tell patients take pain medication beforehand. Like in some instances, like a total joint, a total knee, or someone that's had a manipulation to break up scar tissue, they may need some medication in their system in order to be able to get through the physical therapy, you know, in the short term. That's not something we're going to say, take medication every time you come, but maybe for a week or two, we need to get a jump start here and get you off to the right start.
Because it can be hard work for people, particularly if they're
It's tremendously hard work. I mean, if you watch any, you know, professional athlete stories, you know, when you see, you know, like Joe Burrow get his ACL done and you see he's working 3 to 5 days a week for 4 or 5 hours a day. And, you know, it's like, you know, it's hard. If you imagine that'd be like taking on, if you get hurt, you're basically taking on a part-time job to get better. And it's just, it's a lot of work. And I commend patients that put in the work to get better because the ones that do see a tremendous benefit.
So you're basically like overseeing like a stable of like coaches, people who are able to like coach people to get better.
Yeah, it's tremendous. I mean, there's been a lot of research on your mental approach. We call it pain science, but the pain science approach to an injury and your mental outlook on the injury has a big effect on how you recover from that injury. And definitely our therapists had to deal with a lot more anxiety and stress and things like that over the last year, which definitely magnifies pain and injury. It doesn't mean that if this wasn't a pandemic, the injury wouldn't be there. It's just you take a normal injury and you superimpose a pandemic on it, and that person's worried about their loved ones getting sick. They're worried about themselves getting sick. They're worried about their income.
Sure.
All of that stuff
takes
now this normal herniated disc in their back, and it just sends it through the roof. You know,
completely. I mean, I totally get that part.
Yeah.
Because that worry, like that sort of stress that I think everybody probably has felt in their body at some point, at least during COVID. You know, it's like you wake up and you're like, I am sore and I didn't work out yesterday. You know, like there's a reason for this. I was like so tense, you know.
Exactly.
Wow, that's amazing. I would imagine that like if I came to see you and I had an injury and you looked me in the eye and said, I've seen this a bunch before and I know how to fix this, that would put me in a mental space of being like, great. You know, like the fact that like someone's seen this before and like they know what to do. super
Yeah.
reassuring. Like, I think you're totally right. Like, I'll do the work, like whatever the work is that you tell me to do. But the
Yeah.
fact that like you've seen it before would, as a coach, basically, would like make me feel like I can do
Yeah.
this.
I mean, there's specific diagnoses and injuries we'll work with, and we can take you through a number of tests. And on the first day, if your symptoms respond a certain way, we can tell you there's probably a 90% chance this is going to get better with physical therapy based on
Right.
what we've seen in the evaluation. And that's not just based on our anecdotal experience. That's based on research that has been done in the field on certain things, like I mentioned earlier, like maybe a disc injury and you have pain running down your leg.
Right.
If we're able to do some things and eliminate the pain in your leg on the first day, doesn't mean it's fixed, but it means we have a great roadmap to follow to get it fixed. So,
Got it. And actually, here's another question. What are the bounds of physical therapy? Like, where does chiropractic practice, like, is that within the bounds of what you guys would be doing? Or where are, like,
so there's some overlap.
osteopaths?
Like, we're trained in, physical therapists are trained in manipulation, and in
Okay.
Ohio and Kentucky, they can do manipulation. I would say, kind of philosophically, what we're looking at is more, let's address the underlying issue with strength and flexibility. If we need manipulation as a tool along the way, we'll certainly use that.
Okay.
But in terms of physical therapy, we treat everything from vestibular and balance issues and vertigo, to TMJ joint, to cervical headaches, all the way down to the big toe and to the pelvic floor. We treat male and female incontinence and urinary issues and pelvic pain. So any muscle, I mean, you think of anything in your body that moves or works is controlled by a muscle. Physical therapists can work with that. So it's a very broad spectrum of what we can do.
So you've got, your facilities have, I imagine, tools and exercise devices which can basically like speak to all these different things. Whatever walks in the door, like if somebody comes in and says, I've got X problem, you say, okay, we've got, our exercises and our supporting equipment for that thing.
Yeah, I mean, and I think the biggest part of it is our most powerful piece of equipment is just our hands, and really what we do hands-on between that and between our brain of what we think, each patient is different, and we tailor the treatment plan to their issue and what they need.
Amazing. And so you've been in the room, like I've seen these things on like, YouTube where somebody like hasn't gotten into a terrible accident, can't walk. And then like they do all this physical therapy. And then like at the end of the video, like they're walking, like just starting. You've seen that before.
Oh yeah. Countless times.
That's amazing. That's got to be like an addictive thing to see.
It is. It really is. I mean, that's the thing. I mean, our clinicians, our PTs have changed lives. I mean, and it is really, really cool. And that was the hardest thing. I took a picture of one of our clinics in March of 2020, and it was dark, and it was a Monday. And literally my eyes were just full of tears, and I sent it to the manager of that office, and I said, this just breaks my heart. I think about all the people on a normal Monday that we would be helping, and we're not able to help today, and it was just kind of like, there's a few things that resonate through COVID. I'll never forget that day. I'll never forget having Easter services in our living room versus church. There's just a couple of things that were really defining.
Sure.
And I think that first week we were closed, realizing the amount of people that we weren't impacting was really powerful.
Sure. I get it. So what's the plan for, like, what do you think you guys can do in 2021, 2022 to sort of get back your mojo?
Yeah, I think we, we're doing some really cool things. I mean, for us, it's about education. We've just through our conversation today, I think you've learned a lot about physical therapy and about what we can do.
And hopefully the whole audience has as well.
Exactly. Hopefully, but we really want to get the word out about direct access. We really want folks to access physical therapy first. And other countries like Australia and England and Canada, that's the pathway. If you hurt yourself, you go to the physical therapist and you do a couple of weeks of therapy. And if things are better, great. If they're not, then they refer you on to the specialist that you might need to see. And we really feel like that's what we need to get going in our health system to help with musculoskeletal problems and eliminate the knee-jerk response of, I'm hurt, I need an MRI, I need a prescription for medicine, etc. It's like, well, let's deal with the injury at hand and then see if it needs all that. So
Okay, got it.
we're doing some
So
cool
you
things. Yeah.
so what would be ideal for you guys, and what you think would be best for a patient would be like, if I got hurt, like if I was playing soccer or something and I got hurt, I would come to you guys first, and insurance would be cool with it. Like insurance would be like,
they are.
yeah, that's the right path, right?
Yep.
That's what you're saying about Ohio and Kentucky being allowing people to go directly to you.
Correct. And most insurance companies actually now require, like if you're going to get an MRI, they'll require that you've had 6 or 8 weeks of physical therapy first, and that's good. So
they'll trust your report, let's say, like about the condition of the patient. And if you do get to a point where you've worked with the patient, you're familiar with their injury, and you're able to say, like, we think you need some imaging around this or something, then insurance goes, yes, we agree.
Correct.
Okay.
Yeah,
cool. Got it.
And it can be much more specific. We can say, hey, we've ruled out X, Y, and Z based on how Andrew's done the last 2 weeks with his knee injury. We think it could be this issue, and then the team is so much more focused at that point. So
why would any insurance company, or why would anyone be against that idea? Like, that seems like a great idea.
Yeah, I just think it's education. I think it's just a paradigm shift from what we're traditionally used to, and I think it's just a matter of helping people understand that I think inherently folks think there's more risk. There's a certain comfort, I think, and people think, oh, I had an X-ray, and it's like, well, you may or may not need an X-ray, So I think there's just just kind of a shift that we need to imply to people to understand that, our staff they have terminal doctorate degrees, so they're doctors of physical therapy. And so they've had 7 years of education, 7 years of training, and they're very, very good at, recognizing when we need to send someone right away for something versus when we should treat something, because we can't treat everything, that's for sure.
Sure, that makes sense. Yeah, it's like somebody comes in with like an obvious broken bone, like you'll send them, they need to go have the bone set.
Yeah, I mean, an evaluation is going to reveal a lot, so doing the evaluation, before we do that, it's all just conjecture.
Can you guys do any imaging yourself?
So not in Kentucky and Ohio. In some states, like in Wisconsin, PTs can order X-rays, and I think that'll come over time.
Yeah.
I think there could be some changes in that because it makes sense,
Sure.
Especially for like a limited diagnosis of, I wouldn't want to order like a kidney test. That's not my scope of practice. But if we wanted to, get an MRI or an X-ray of a peripheral joint, I think that should be something down the road that comes to play.
Got it. I mean, outside of a global pandemic, which slows people and sort of confines them to their homes, I imagine that your line of work, your business, is a sort of year-round, steady stream of customers, because people are constantly moving, and unfortunately, they're getting hurt sometimes, or they're doing they're running a crazy marathon, and then they need help afterwards, right?
There's definitely seasonality,
Okay.
There's some back-endedness to it, like in the January, February timeframe, folks are maybe more prone to put things off. They have a big, large deductible they don't want to chip away at, or, they're maybe just not as inactive because it's winter around here.
That's what I thought you were going to say, was that like if it's like the dead of winter, like people aren't running a marathon, they're not getting hurt. Like, do you think that there's practices in California that where the weather's better, where they're like, it's like a constant?
I think it's more steady. Yeah.
Yeah.
I mean, thankfully ours is not huge swings. We might look at 10% fluctuation of seasonality,
Yep.
But we try to, one of the things that we do is through our community service and education is we offer a free walk-in visit called a bioexam or a B visit to anyone out there. And that's a 5 or 10 minute interaction where folks can come in if they're getting ready to run a 5K, and we could talk with them for 5 or 10 minutes and say, hey, look, here are your really big potential areas where you could have a risk, So we love helping people on the preventative side. We love helping people, avoid injury as well as much as treat an injury. We love helping our patients, avoid getting hurt too.
I feel like I should come in for one of these. I could use it. I run and I'm like always feeling sore, and I feel like someone's either got to tell me like that's not right, or they'll be like, well, you're over 40, like it's okay if you're sore after you run.
Well, sometimes there's some tweaking involved. It's just a matter of, hey, you've been focusing on this for a long time. You forgot about the other side of the teeter-totter, so we just got to kind of look at that.
Okay, Matt, I'm coming in. I'm
Okay.
gonna come in. We'll meet each other in person when I get out to Ohio or Kentucky, rather. Sorry.
Yeah, sounds good.
Well, Matt, thanks so much for joining me on the call. Really appreciate you being on the podcast and letting my audience understand a bit more about your business and about physical therapy in general and direct access.
Yeah, that's right. My pleasure. Thank you very much.